Angus. I This is going to be a popular episode because, um, well, I mean, I think we tend to be very interested in how we can help our kids. We spend unlimited amount of time and resources on our kids. Sometimes we don't do as well for ourselves, but I always have, whether it be clients or friends or family members, asking, okay, my kid is doing this. Does that have anything to do with what you do? And so I personally, I mean, I see some kids, but it's definitely not my forte. And so I've loved getting to know you a little bit and knowing the services that you offer in town. And I'd love to use this time to be able to share some information specifically about kids, and kids have a pelvic floor too, and some of the things that kids might experience. So thank you so much for taking time out of your busy day to chat with me.
My pleasure. Thanks so much for having me on.
Yeah. Will you start, Angus, by telling everybody that doesn't know you a little bit about yourself and maybe how you got into this area of practice?
Of course. I'd like to think that probably the vast majority of people don't know much about me. So my name is Angus MacKay. I'm the owner and physiotherapist here at Kids Physio Group Kelowna. And my physiotherapy journey started back in 2015 when I started with Kids Physio Group as their volunteer. I was looking to get into physiotherapy school, and I found this awesome opportunity at this pediatric company. I was like, what is pediatric physiotherapy? And I stepped inside the doors and I just saw the magic that was happening every day. And that led to an office manager position. So I then started running the desk. I went from being a bartender for like 9 years to then all of a sudden going straight into an office job and needing to get to the other side of the desk very, very quickly, because it was just so cool to see what the physios were doing day after day, the goals the kids were hitting and how they were doing it. Like every kid was just so excited for physio. Like, this is fun. I was like, good, this is how it should be. So then my wife and I moved down to Brisbane, Australia for 2 years. And I went and did my physiotherapy degree at the University of Queensland. And then when we came back, we both worked back in Vancouver for a couple of years, and then the pandemic hit. And we welcomed the birth of our firstborn, Tilly, in the start of 2020 as well, right as the world shut down. And we discovered that we needed help pretty urgently in terms of managing a toddler and also getting our own health on track. So we moved back to Kelowna, and then it had always been our dream to start something like Kids Physio in Kelowna. And so in August of 2021, we were actually able to achieve that dream. And so Sid and I opened the clinic together, and it's been the most incredible and whirlwind year over the last year.
I
And
bet. Wow.
yeah, so it's been fantastic. I couldn't imagine life as it is right now. I don't think I ever had this vision. I always wanted to do this, but it's wild to see where life has taken us. And I love how much we've been able to impact the community and integrate with providers like yourself, to help give kids in this community the best care that they deserve.
Well,
And so
here's
my
what
pelvic health
Well, that's
journey.
what I was gonna say. I want to just say, first of all, as soon as I met you, I could tell you'd be good working with kids. Like that was something I could tell as soon as I met you, that your energy would be great with kids. So I didn't mean to cut you off, but yes, please share how did you start doing kind of the pelvic health component?
Well, thank you. I'm a big goofball with the kids. Like oftentimes I have to kind of rein myself in and say, okay, maybe you're having too much fun. Maybe the kid needs to have a little bit more fun, I guess.
Yeah.
But pelvic health really started for me because we started to have either patients internally, who were already patients of ours. We started to notice some more pelvic health related concerns, or patients outside of our clinic reach out to us with pelvic health related concerns. And at that point, we had no one on the team who was pelvic health trained. And so, we reached out to local clinics. And I think one of the first people I reached out to was Corinne Wade over at Care Physiotherapy. And I said, Corinne, we've got some patients for you. Can I send me your way? She's like, I don't really see kids. And I don't really know that many other people in the community do. So why don't you do it?
I can see her saying that. Yeah.
So I was like, okay, thinking it over. And we had a number of other. Kids Physio is a franchise that goes coast to coast now, all the way from Victoria to Halifax. And we have a number of other practitioners on our team who are pelvic health certified. And I'll be honest, I never pictured myself to be one of them. I was like, pelvic health, that's not for me. That's not exactly what I want to do. I had been exposed to it into my physiotherapy degree, and had seen a bit of it. And I was like, yeah, I think it's super interesting. I love it. There's huge impact in their area. But you know what? I love the stuff I do with kids already. But then the requests kind of kept coming in, and we had no place to send these kids. I was like, you know what? There is a dire need for this in the community. Let's do it. Let's just dive right into the deep end. And so that was right at the end of 2021, earlier this year. And wow, it is just exploded in terms of, this is my core area now. This is over 50% of the patients that I treat are for pelvic health concerns. And I love it. I never expected to love this area as much as I do. And I think the big reason for that is how huge an impact it is. For the younger kids, the impact on the parents is massive. And I love that. But it's the older kids, it's the 12-year-old who comes in to see me who says, I've never been able to hold my bladder in, or I constantly am constipated, I'm having poo leaks. And if I'm able to make a difference with them, even if it's just a small difference, it's massive. And just the being able to change their life and impact their life, even in a small aspect, it fills my cup. So
Well, and I think for this area, you really have to be comfortable talking about anything. And like I said, I can tell that you'd be someone easy to talk to. And I think you segue really nicely into one of the misconceptions that pelvic health equals internal work. And I think that there's this belief that a lot of people have. I think that's one reason people don't like, as adults, to reach out. They feel nervous that pelvic health has to equal internal work. But I can imagine a lot of parents would equate that same thing with children and think like, I'm not going to see a pelvic health physio for my kid. They're probably going to do something internal. And I think too that a lot of people would be like, why is a man doing that? And again, I don't think that's fair, but I know that that's something that enters people's minds. Can you speak to that? I'm sure that's a question you field all the time. So
100%. I have fielded it before kids come in the door. I field it on social media when people are just asking like, what exactly what are you gonna do? And 100%, I also have that knowledge, and that I am a male in this profession, and I want to be very careful that anyone that I'm working with feels safe and comfortable in my environment. And in the field of pediatrics, the lovely thing is that there is no place for any sort of internal exam. The kids don't need it. There's so much I can do outside of that it is not, I would never attempt it. It's not part of my training. So you can rest assured that never will I be suggesting anything along those lines. The most invasive part of pediatric pelvic floor therapy can sometimes be an external observation of the perineum to see what the overall health of the skin is, how those muscles are activating, if there is any other concerns that we need to refer on to a specialist for. But typically, I rarely do that with a lot of my kids, because so much of what we do can be answered either through subjective. So what the parents are telling me, what the kids are telling me, what I can coach the parents, be like, when you get home tonight and you guys are having a bath, these are the things I want you to look for and check out. I don't need to see them. You can be my eyes. I'm going to do a really good job of teaching you what you're looking for. And then the other thing we sometimes do is an external palpation. So feeling what those muscles are doing. And we do that in areas that, what can be a little uncomfortable for some of the kids. So I approach the idea, I present it to them, and then I let them make the decision. So if it's something that they're comfortable with, then we do it. If it's something they're not comfortable with, there's so many other options we have. So for me, the areas that we sometimes palpate are just, along the kind of the belt line, right underneath the sit bones, or right by the tailbone. Nothing crazier than that.
And I think that's important. That's how I practice with adults too. And I think that just understanding that it doesn't mean that has to happen your initial appointment. That is something that you will talk about with them if you feel necessary. Some people want you to touch and palpate because it helps them understand, and other people don't. But that would always be a joint collaboration and decision. It doesn't mean it's not part of a checklist. So yeah. I think that's kind of one of the most important things that I wanted to shed light on. We're obviously going to get into kind of specific things that you treat and assess, but I still want to set the stage for like what happens, what's kind of the chain of events if someone has, where are you seeing most of your referrals? Is it from, doctors or other healthcare providers, or people are Googling things? And can you talk a little bit about what that looks like, the process for someone actually bringing their child in to see you?
So I'd say our largest source of referrals, and this goes for both pelvic and for pediatrics in general, is what we call word of mom. It's parents talking to other parents saying like, I don't know what to do. Where do you think we should go? And the more that we interact with the community and spread knowledge, the more that we see these patients come in and land in the right place. So, you know what, like social media is huge for us, Facebook mom groups, Facebook parent groups as well. Instagram, Google searches is a huge source of referrals for us. And a lot of times what I do before we even have our initial assessment is I have parents reach out by email, by Instagram, by phone call, and they say, hey, I just, this is an investment of my time, my money. I wanted to make sure, is this something you think you can help with? And we kind of talk through things, and then we either make the decision, yes, this is a great service for you, or you know what, no, I think this is something you should go talk to your dietitian about, or you should go talk to your GP about first, and then maybe we'll go check some things off. So that's a huge source of referrals for us. We do, of course, we're getting our name out to GPs in the community to know that we're here for these services. And then specialty, Kelowna is lucky to have a pediatric urologist and a pediatric nephrologist. So we have some referrals from them as well. But the large majority is that word of mom.
And then generally it would be kind of the same as quote unquote adult physio, is that, it's direct referral. You don't need a referral. You come in, you have an assessment, and then there's a treatment plan that's individual, right? It doesn't mean that you have to come for a certain number of sessions or anything. And will you also describe, because I think a lot of people picture, how is my 3-year-old going to do physio exercises? So can you talk a little bit about what's different about kids physio and the environment?
Yeah, that it has to be fun. If it's not fun, what the heck's the point? And I picture that with my own physiotherapy as well. If I go into a physiotherapist and they're just going to do some manual work on me and do a little bit of release and then tell me to come back in about a week, I'm not going back to see that physiotherapist. I want exercise. I want to be moving and doing things. And so very much we base our physiotherapy off what the kid loves to do. So for example, yesterday I had a kid who loves the Marvel movies, and that's huge. Or even more popular right now is Minecraft. So we'll make Minecraft games. We're going to do core exercises, but you're kicking over creepers. We're going to do crawl outs, that is getting back mining materials for this. We're going to do a cart race, working on your upper abdominals, your lower abdominals, and whole body coordination at the same time while we're exploring a cave. So and it depends on the kid. For our younger kids, of course, we can do amazing imaginative play that's all movement based. For our older kids who they're starting to say like, I'm getting a little bit older, I want you to treat me a little bit more like an adult, we'll do a lot more like exercise and movement focused sessions as well. But again, we're still trying to keep it fun. We want it to be really tailored to them and what they like to do.
Yeah, what makes them tick. Exactly. So I kind of picture, I actually, when I get a lot of questions is moms at school drop off, where people will be like, do you have a second to talk? And they'll pull me aside and ask me questions. And so I thought that might be a fun way for us to go through some of the things that you treat. One I think can think of is bedwetting. So those kids that, the parents are starting to think like, oh, I don't think I want to send them for a sleepover. I'm still putting them in pull-ups and I don't think this is normal. So can you talk a little, and I see this on moms groups, Facebook groups all the time. And everyone has so many different suggestions. Can you talk about bedwetting?
100%. So I think first thing with bedwetting that we want to address is your child developmentally at the right age to be dry overnight? And typically we see with kids that if you're starting your potty training, so anywhere between the ages of like 3 to 5 is a good age to start. Younger, you can definitely do it younger. Usually we recommend a little bit older, just because to be able to be continent takes the ability to stop what you're doing, to recognize that body signal that I have to pee, to be able to go to the bathroom, to undress yourself, to sit on the toilet with good posture and wait until the pee or the poo happens. And you know what, this can be a process that, your 18-month-old might be able to do. Sure. Your 3-month or 3-year-old might be able to do, or your 5-year-old might be able to do, but you want to meet your kid where they're at. So once we start to see that dryness overnight for about usually a period 3 to 6 months, or starting during the day, then we can expect that usually the bladder overnight it has built that capacity to hold. So in kids who kind of quote unquote fail potty training and they're wetting the bed, for us, it's a question of what is causing the bladder to not fill or to empty prematurely. So there's things that we want to rule out. We want to make sure that there's nothing medical going on, like say like diabetes, that we want your doctor to look into and make sure we rule out. And again, that's pretty rare. The majority of kids that I see for bedwetting, the main causes are either it's a genetic factor in which their nervous system and their body is still maturing and they just haven't reached that point. And that's the one that usually that's when the doctors say they'll grow out of it. So their body just needs to get a little bit older, start to make sure that the bladder has that storage capacity and is getting that signal from the nervous system and your endocrine system to hold all night. Now, if the parents or their first cousins, they're like, oh yeah, I went to bed till 9, 10 years old, that's likely the case. And it doesn't mean we have to wait till 9 to 10 years old. We actually, in those cases, those are my favorite ones to treat because I was like, oh, I got a plan for you. We can work on this right now if you want to help that bladder mature and keep you dry overnight. But the other big reasons is for one is constipation. Like if there's poo inside that body that isn't coming out, it's going to push in that bladder and that bladder does not have the capacity to stay full all night and it's going to empty prematurely. But the other reasons sometimes are things like sleep apnea, tonsils, the ability, if your child isn't going into a deep sleep every night and they're constantly kind of waking up, then their body isn't switching that nervous system over to be able to fill and hold that urine all night. So their bladder thinks it's basically during the day. It's like, well, I'm going to continue to empty every 2 hours because that's what's healthy and good for me. So for the large majority of the kids, what we do is we do a couple screens. We send them back to their GP if we need to rule some things out. If we're like, oh, these are the things we're concerned about. But the large majority fit into either the constipation category or the genetic category. And then for those two, once we get the poo out of the way, we work with the GP for that. Then we work on a bit of a sleep training program where we basically target where that leak's occurring. And then we work on training the bladder to be able to hold a little bit longer and a little bit longer and a little bit longer. And then we have success.
I'm sitting here thinking in my head, I'm like, we need to do like a whole episode on potty training. But I do think that that is something that people will be very interested in just a little bit more right now, because this is something again that fills the Facebook communities. And again, I'm not expecting you to take the whole episode to talk about this because I think we could. But will you talk a little bit more about that? In some ways, we cannot rush that reflexive system. I think a lot of people are feeling either rushed by their daycare or rushed by social pressure to potty train their kids earlier. Will you talk a little bit about, again, like that reflexive system that just needs time to be able to sense that?
Mm-hmm.
Yeah.
And I think where I have to acknowledge my limitations is in the whole potty training regime is if someone comes to me and it's like, I've failed potty training, or my child, we just haven't been able to proceed with potty training, you know what, their school's asking for it, or you know what, we want this for us. And that's totally fine. You want to be comfortable with your routine and what's best for both you and your family. So in my area, what I do is I make sure that, you know, are they developmentally ready for this? Can they go through the steps that we kind of talked about? Are they able to undress themselves? Do they have that ability to feel or hear the messages that are coming from inside the body, that interoception? What's their pelvic floor doing? What's their core doing? So I go through my physio checklist. And if my physio checklist is, you know what, you are absolutely ready for this, and it's more that kind of behavior, we need to learn more about why we want to potty train. In those cases, I usually refer them to a potty training group who are the experts in that. But for me, I stick within my expertise at this point of really making sure that we're ticking all our boxes of, is your body ready for potty training?
Yeah. Well, and I think too, like if I think about like the adult population that has a hard time with like urgency or sensing signals, we talk about the reflexive nature that learning to more listen to your body when it needs to go pee than going all the time, like just in case. And I think what I was kind of wanting to touch on a little bit was that I think we quite often teach our kids to go for a treat, like go every half an hour for a treat so you don't have an accident, but you teach a system that's not listening to the fill, right? Like you're not listening to the fill of the bladder, you're getting a treat, right? And
Exactly.
so
You're not on your body's schedule.
yeah.
You're on the external schedule that's been imposed upon you.
Yeah. And no different than, we tell people that say, or same about eating is like, eat when you're hungry, not on a schedule. And so I think sometimes just parents understanding that your kid's not failing if they're not potty trained yet, but like you just said, that maybe they aren't getting those signals yet, but being patient and waiting for your kids to recognize those signals will really serve you well. Yeah.
Mhm. And I think we can give kids so much credit sometimes because they are these unbelievably in tune tiny creatures. They definitely feel like creatures sometimes in how they act. And I definitely believe in letting a child lead the process and not forcing something upon them that, you know what, why would they want to do that if they're not yet ready for it? And sure, there's definitely certain cases where they're reaching the age and you're like, I think it's developmentally appropriate for you to start learning how to stay continent all day. Your bladder should be able to hold a day, your bowels should be able to empty when you want them to. And we want to make sure that also we're setting up for socially appropriate things. We don't want them getting to a point where all of a sudden they've developed, so their cognition is developed and they're thinking, oh my goodness, I'm pooping my pants all the time. No one wants this. Like my friends notice this. And for me, that's a big reason why we don't wait to see what happens. After the age 5, 6, we make sure that if there's any sort of bedwetting, if there's any sort of incontinence, that we're addressing those concerns. Not necessarily from a medical standpoint where we're worried something's going to happen, but from that social standpoint that there's going to be so much social anxiety for our kids.
Mm-hmm.
And so much of that social pressure for them that we don't want to cause anything else.
Yep, absolutely. Talk about, because you've already touched on constipation, but this is something exactly, I think that's where my mind goes. As soon as I see like in the mom groups, someone saying like my kid's bedwetting, right away I kind of say, I wonder if they're constipated. And sometimes I'll say that, but I think sometimes that can fool you because they might be bypassing some stool. So something's coming out or they're actually going to the toilet. Will you talk a little bit more about that? Because I think like sometimes it's hard for parents to know if their child is constipated, and how do you actually know?
I'll be honest, constipation is my nemesis. I wish I could just have a magic bullet and I said, you're not longer constipated anymore and you're not constipated anymore.
Yeah.
Um, and so the obvious ones is we start with the obvious questions. What does your poo look like? So one of the things I always love with community chats is the idea of destigmatizing potty talk. And I'm not talking about like when my 2-year-old daughter comes up to me and says, Daddy, you're a poo-poo head. Like, well, that's not really appropriate, but
Yeah.
thank you. You're a poo-poo head too.
Yeah.
But talking about what happens in the toilet, like,
Mm,
let's see your poo. I'm proud of that poo. That's a great poo. Well done. Or it's like,
mm.
oh, that poo looks a little bit hard. How was that when it came out? I think we need to either drink more water, have a more fire, try eating the rainbow, things like that. But I love the idea of normalizing what's coming out. Let's talk about it so that we can first analyze, okay, is what we want to come out happening, or is there something else we need to address? Or is it that we're not addressing because we've never talked about the elephant in the room because we're not comfortable talking about our poos and peas? So with constipation, the obvious one is, does it look like rabbit droppings? Does it look like that really constipated poop? Is it this massive dried up log that's just been sitting in the colon and the end of the rectum for days upon days? But then you get into the more subtle things. So it's really hard to poo. Things like straining, things like fresh red blood from a bit of a tear. If the poos take just forever to happen, if they're on the toilet for like 60 minutes, if they're holding their breath, that sort of thing. And then you have the stuff that's not necessarily related to the actual poo coming out. So your things like, are they not hungry? Are they really refusing food or only eating little tiny bits? Like, I'm not hungry. And they're not really sure that they're not saying like, oh, I don't feel like backed up. I don't have bloated, but I have no appetite. You can have bloating, you can have distension, you can have lower abdominal or back pain. You can have like shyness or avoidance, especially in the younger kids who, if they're still in pull-ups, they're going behind the plant in the living room. They wanted to go strain and have that bowel movement there. They don't want to have it someplace where you can maybe watch. Those are some of the things that we look for. And then sometimes also that agitation. Like if you think of yourself as an adult, like it's hard to like, if you put your mind in the mind of a child, but if you hadn't pooped in 2 weeks, if I think of this, I got sick recently. I didn't poop for a week and I was irritable. I was a crabby individual. I had to remind myself, it's like, okay, yeah, calm down. It's not everyone else in the world's fault that you haven't pooped. You can do your normal tasks, do this. So those are some of the things. So you have these poop things, and you have these non-poop things that can all paint a picture together that your child may be constipated. Now, the worst part for me is that you can have a kid who doesn't present with any of those signs and is having a regular poo every day and still has constipation present. 50% of kids who are daily poopers and have otherwise functional signs of things like urge incontinence, urinary incontinence, bypass diarrhea, or nighttime wetting. So if they're having some other functional complication, and even if they don't have signs of constipation, I'm always thinking, is there poo in there?
So what do you suggest? Do you suggest they go for like an X-ray?
I would, from my training, which is a very American-based training where they very much focus on the biomedical and the psychosocial as well, but it's a very biomedical focus. Their recommendation is for an X-ray or an ultrasound, which a lot of doctors and pediatricians that I work with so far have not really recommended. They base their diagnosis based on objective history and the DSM. And they say, based on what you're telling me, I don't need to look and see if there is impacted stool in there. We're going to treat it as if it is and get rid of it. Where that's difficult for me sometimes is, yes, but I want to know.
Yes.
I want to know when it's gone so that I can proceed with other parts of my treatment and not have in the back of my head, are we just slow progressing? Are we having treatment failure because poo is just not giving out of there? And you read some of Dr. Hodges' work from down in the US and you're like, let's x-ray, let's just take a look at it. It's a small dose of radiation. And I don't want to say come from a place that I want everyone to get an x-ray. I want everyone to get imaging, because I don't believe it's my place to say that, because I also don't know the other sides of gastrointestinal kind of medicine and the other things that we should be looking at. But so in that sense, I refer to the doctors, I advocate for treatment or assessment. And in that case, if the doctor comes back with whatever they're coming back with, I kind of work with that. And then if we hit a wall, that's when we come back to it.
Mm-hmm.
But otherwise,
Yeah.
I wish I was Clark Kent. I had X-ray vision. I could just look in and be like, oh yeah, you've got rectal distension. Yeah, you definitely got some constipation going in there.
I think though that the part about just being like talking about it, and helping our children realize their own bodies. I mean, I have two very different kids. They eat the same thing, but very different bowel habits. And so I think like, I always think of it as like helping you see what foods you need to eat more of, or helping you notice when you need to drink more, or like you said, call me if you're unsure and I'll help you look at your poop. But I'll never forget this one client that told me, she came in, I think she was having incontinence. She was a grown woman. And as we started talking, she said, I've always had a very big issue with constipation since I was a child. And I used to plug the toilet all the time and I'd get in trouble. And I was being told I was using too much toilet paper. So I went down on my toilet paper. And it wasn't until I went to university and saw everybody going all the time that I realized once a week wasn't normal. And she talked about how she's like, I was just getting in trouble all the time. So I nobody ever looked and no one ever explained that like she was plugging it because it was such a big bulk, but no idea until she was in university and seeing other people. But I guess where I'm going with that is that as someone that treats adults, you see that the habits that we start as young people move forward to when we're adults.
Absolutely. And I loved that story. I actually listened to your earlier episode with Marinetta on constipation. That story just rung so true for me, in that I love for people to know what is and isn't normal, and not necessarily to remove the shame of it. Like, this is something that we have so little control over when it happens internally. And there's so many things that we can do to try and set your body up for success.
Mm-hmm.
And when I heard that story, it made me think of, I had a patient last week and I honestly laughed out loud with this. And she described that she has this is the mom telling me this, for her kiddo. She has a guest book at her house. And in that guest book, it is the name, the date of when you came, your reason for visiting, and what your last poop looked like.
Ah.
And she said it's just such a weird icebreaker for people, because they'll go to the toilet, they'll all of a sudden see this guest book and they just laugh out loud, because it's so out of the normal for everyone, but it just introduces this great conversation. It's just like, it doesn't have to be such a stigmatized area. We all do it. And it's one of my first things that I tell kids, like, one, none of this is your fault. This is your bladder and bowel not doing their jobs. These aren't accidents. These are your bladder leaks or bowel leaks because they aren't able to do their job for some reason. And two, everyone poos.
Yes.
Everyone poos.
Yeah. And why are we spending so much time on this? Well, because some of these very reflexive bodily systems are what's kind of at the heart of why you're having your symptoms, right? Is
Mhm.
once, because this is the pelvic floor is such a reflexive area of our body. So usually it's kind of detective work as, okay, why is it not working well? Because I know it's not that you're doing something purposely. It's something about your habits or something about your beliefs or something about the way you move that is creating some of this. So I think that some of our just natural bodily functions really play into that. What about, I also picture a mom recently that said to me, my kid won't pee. She sits there and she dances and dances and dances and dances. And, she's getting a little bit of leaking, but that wasn't her biggest reason. She's just like, should I be telling her to go all the time? Like, should I be telling her to go all the time after recess or what have you? But she was looking for a bit of direction. I think she was kind of like, I can't get her to pee. And we were talking a little bit about how they want control of their own bodily functions. Like our kids want to be able to control that themselves. And sometimes I think it is an element of control that they're trying to
100%.
instill. But can you talk a little bit about that? Like quite often people, the question is like, what's going on with them, or why can't they go? Do they have is their pelvic floor an issue that they won't go pee?
Yeah, and I think actually you hit a couple of like key thoughts that I honestly like plague my brain. Is the why of these things sometimes is so hard. The why is my kid doing these bladder habits? The why are they constipated in the first place? What can we do moving forward? So that why question can be so tough. In the child who doesn't pee, the why could be, is it a bit of control? Is it, I don't want you to tell me when I need to go. I want to listen to my body. But in that, is their bladder a bladder that has extra large capacity because it's been stretched out? And now that child only senses urge when it's absolutely at its breaking point. And then at that breaking point, you have a bit of leak come out, and then maybe it shrinks back down and you lose that urge sensation. So is this a child that physiologically cannot feel that urge anymore? Or is this a child that, because of constipation and difficulties with actual bladder dysfunction, is that child unable to feel interoception? Is this also a child that potentially has core instability or a diastasis, and because that instability has lost that ability to feel that interoception, or is so overwhelmed with other sensations that the bladder is the last thing that they want to think about, that there's so many other stronger messages coming through to them. So the why can be very difficult. But the nice thing is that sometimes we just start with the basics. So we start with, okay, let's start with your basic hydrotherapy or your bladder therapy, your urotherapy, sorry. And how much fluid is going in? When are you going to the toilet? When you're going to the toilet, what are you doing? Because we know that with really good hydration, with really good habits, with a bit of movement and a bit of like setting yourself as for success, over time, you should be able to at least see an improvement in some of these things. So usually that's where my first place is to start with a lot of patients, is just starting with the basics. If we start you out with the bare bones, to make sure that we're checking all those boxes, what happens? Then we start investigating the other why pieces as well. But for the kid who's having any sort of pee difficulties, my first thought is like, how much fluid is going in there? How much fluid is going out? And so oftentimes one of our first things we do in terms of assessment is a diary. So we get a diary to go home with the parents for 3 to 5 days. And I want you to track roughly how much water or fluids or fluid-like foods are going in, and when are these pees happening. And if this is a kid who's only peeing once a day, then we got to work on that, because a kid by the age of 12 should be peeing anywhere between 4 to 6, 4 to 7 times a day. Should be a nice clear yellow or opaque color, and that stream should be coming out strong. It should be coming out in one consistent stream, and it should be easy. They should be able to keep breathing throughout the entire process. So we want to make sure for this kid who's not peeing that all those things are in place. And if not, why?
I think it's funny because I mean, I don't treat kids, I treat adults, but I still have adults that come in with the same questions. How often am I supposed to pee? I don't know what my poop's supposed to look like. They have all the same questions. And I spend a lot of time that first session with my terrible drawings, but drawing like, this is what the bladder looks like, this is how the pelvic floor relates, this is the brain, and just drawing out what a normal responses of that area, and then talking a little bit about things like, okay, what's at play here? Well, one, it's your brain. Your brain's prioritizing your bladder all the time. Like you go as soon as you get any small message, and so you're creating almost like this overactive bladder. Or, you know what, we've established you have a lot of pelvic floor tension and you're carrying a lot of tension, so that pelvic floor can't hold up the world all the time. It's going to start to cheat a little bit, or it's going to start to fail a little bit. And just sometimes just explaining to them how the system naturally works, and then where some of the issues could be, and then tackling them. But this is not something I say all the time, is that because this is such a reflexive natural system, we don't know about it, and you're normal to not be thinking about it. But if there's an issue, we have to kind of break that down. And I think like the benefit of working with kids is that you teach them about their body from a young age, because a common theme through the adults is, I didn't know this about my body. And I think that I always say, like, try to make it in a language that they can help tell their kids too, about listening to your body. And I notice sometimes my kids, they'll sit down and they'll rush their pee or something. I'll be like, you're not supposed to push it. Like, let it out easier, or take your time, or you're not supposed to do that on the toilet. Like, just talking to them a little bit about what's normal or what have you. And I think that's the benefit of working with children, right? Is that helping them set those good habits from the beginning. And just like you said, normalizing, explaining. I think that's a huge role we play as physios.
And one of the great things about working with kids as well is that they have so much adaptability to change. They
Yes.
can change so quickly, which is amazing. And it's tough with the gut as well, because so much of our bladder and bowel takes consistency and takes time. So we often describe it as a marathon, not a race for our patients. But sometimes with the motor skill, you can be like, oh, belly breathing. I would like you to breathe more through your diaphragm. We're going to go through coaching this for the next few sessions. And you start off with one cue and the kids got it. You're like, wow. All right.
Yeah.
On to the next one.
What about, you talked about diastasis. I have another, I'm going to tell her to listen to this, but I've had someone else reaching out to me via Instagram lately, just asking, she's like, my child has diastasis, or, they've had a hernia, and I've been looking to see if they have, if this is a surgical hernia, and because of different things that have been in their medical history, I'm wondering if I should be doing something for her diastasis. Can you speak a little bit to, I'm sure most people aren't bringing their kids in for diastasis, but maybe it's something you're picking up a little bit more. And a lot of people associate this just with pregnancy. So they'll kind of be like, what the heck? How can kids get diastasis? Can you speak to that?
Absolutely. So I see diastasis in like 90% of the kids who come in for pelvic concerns. So especially in children, diastasis is primarily an issue of pressure, in that there's too much pressure being created in the abdomen, and that pressure is not being regulated through the transverse abdominis and through the anterior abdominal muscles. So, but part of that is also understanding the development of the core. And so for the ages of 0 to 3, as your abdomen is still developing and all your core muscles are still, getting stronger and starting to work better and developing that anticipatory action as you're crawling around as a baby, as you're learning to walk, as you're running, as you're falling, all these different things. So from the ages of 0 to 3, it's not super common, but you can definitely see a diastasis present as a baby. And in those ages, up to age 3, it should resolve. Sometimes you can resolve up to age 6 or 7. But you have people who, genetically have a bit of a larger separation between their abdominal muscles. So for anyone who's not familiar with what a diastasis is, it is a separation of the 2 sheaths of your abdominal muscles along your linea alba that goes right along the middle of your belly. And you can have different forms of diastasis. It can be above the belly button. It can be below the belly button. It can be kind of basically from your ribs all the way down to your pelvis. It can kind of just be around your belly button. And for some kids, we want to make sure that if we're seeing this, is there anything else functionally implicated? So in a baby that is developing absolutely perfectly, and their core is working well, it's developing, we're seeing a bit of diastasis, we're probably not going to address it. We're going to do our normal developmental screen. We're going to see if there's anything else we need to do, but we're going to wait and let that baby kind of grow and learn. Now, there's things we want to make sure that we don't see, that we're not making sure that there's a hernia present, that underneath that diastasis or that doming is still some muscle tension, like that there is an intact sheath there. But for the large majority of kids, that doming is occurring because of pressure. So for when they're coming in for pelvic concerns, that's that's my signal right there. If they're having a diastasis and they have pelvic concerns, then there is some sort of functional implication of pressure there. So we absolutely treat it in kids with pelvic concerns. But for the kids who are coming in for non-pelvic concerns, we'll take a look at it. We'll see if we want to do anything. But you know what, a diastasis can be normal. You can see some Olympic athletes who have, you know, rectus abdominis that is like, they're like a division sign. It's like Moses parting the Red Sea in the middle of their belly. And they're obviously able to contract and use their abdominals really great. So the big question is the diastasis that you're seeing, is this doming functionally implicated in what you're trying to treat? And if so, address it. If not, let's make sure that we're aware of it, but let's also make sure that the kids aren't fixating it, that they look at their bellies every time they crunch up for the next 20 years and say like, oh, this is responsible for all my problems right here.
That's what I always describe to people, is that like it can be just a coordination issue of your muscles. Because I think sometimes it's pathologized, like you said, and people think that they have to cure it or they have to heal it or we have to somehow get that back together. But more, if you don't have symptoms, then it's probably just an anatomical variation. Or if you do have symptoms, that's how cool the body is. You can work on coordinating the muscles better so that you don't have the symptoms. It's not always just about the space. But just I'm sure that you see, you know, you're not only working on like the pressure and the muscle coordination, but just things like how they stand or how they sit, how the rib cage is positioned over the pelvis. My youngest, I noticed when he was really little that whenever I'd be changing his diaper and he'd be trying to kind of, you know how they fight and squirm and try to, I'm like, this kid has a diastasis. Like I could just see like, and I don't remember that in my daughter. But I also always noticed that he'd stand with his pelvis poked way out in front of him. Like he just naturally stood with his rib cage quite far back. And I could see like, oh, I can see why he has a tendency for some of that. He carries himself. It's kind of sorted himself out. And I think that comes from him being involved in different sports and activities and learning to move his body in different ways. Sometimes kids have some major movement preferences, right? They do a lot of the
Oh
same
yeah.
things over and over again, or
And they're master compensators.
yes, exactly. And sometimes I'm sure that's what you're doing in a lot of your therapy, is just teaching them to move in a different way with variation. And I'm guessing that's when you see a lot of the things sort themselves out, right?
Well, especially what we said, like if we can teach a kid to move a little bit differently, and not being said, there is such a wide range of what is normal movement, what's typical movement. We don't want to put everyone in a cookie cutter and say, oh, you don't match this cookie cutter. You
Mhm.
don't match this functional assessment I'm doing, and I'm going to make sure that you tick all my boxes. We make sure that it's addressing their needs and concerns. But if you see something that is, you know, a movement related to that's causing pain, causing dysfunction, causing or inability to coordinate, then we can address it. We can try and change it and give them some cues, and then these kids can pick it up really, really quickly. And for those who don't pick it up really quickly, sometimes that can be a bit of a light bulb for us. You know what, something else is actually at play here. What if this is a kid who, you know, the clumsy kid or the child with DCD who's been undiagnosed, or what if there's something else at play that we want to talk to your doctor about? And those are the rare cases
Mhm.
that usually these things are picked up earlier. But I love the idea of taking a look at how a kid's moving and being like, look, we can do this a little bit differently. Like you're up on your toes because you're trying to record pelvic floor tone, or your lumbar, you've got a little bit of lumbar lordosis because you know what, actually you've got a bit of constipation in there. Or it's like, or you got a hip pain because you can't twist. Let's try and twist. It's like, oh, you just twist like this. Oh, well, that feels better.
Well, and I think that as I sit here and listen to us talk, I think just to be able to tie it all in for people, is that we're talking about specific symptoms like constipation and bedwetting and urinary symptoms and diastasis, and they are related to the pelvic floor. We wouldn't just give kids Kegels, because the pelvic floor is only as good as its environment, I always say. So sometimes it's more like, okay, we know this is a reflexive muscle. We know that it inherently works. What's going on here? So it's not just about tightening the pelvic floor, but setting up the environment so that the muscles do work more optimally. Is that right?
100%. I love that. The pelvic floor is reflective of the environment. That's great.
Yeah, yeah. The pelvic floor is stupid. It doesn't have a mind of its own. So, what are there any other things that bring kids in a lot in a pelvic health world that I haven't asked you about?
Yeah, I mean, so you get your like I address it in terms of there's the diagnoses that come across, but it's like really when it boils down to is pee coming out when you don't want it to,
Yeah.
or is it not coming out when you want it to? So is that, like, for example, giggle incontinence is a rare disorder where you have a big belly laugh and fully emptying happens. And these poor kids, we work a lot on like the core and we work on that pelvic floor strength. But the idea both for bladder and bowel are things coming out when I don't want them to, or are they not coming out when I want them to? So those are the very basic ones that I talk to families, because families understand, like, you're right, that poo shouldn't be coming out then. Can we address that? Other things that I address is pain, of course. I don't want any kid to have any sort of pain in their tummy, in their back, or in their perineum, in their penis, in their vulva. So that is something we address as well. We have kids who pee too much, poo too much, poo too little, pee too little. Another area is that is quite tough is trauma. So kids who undergo trauma, whether that is sexual in nature, physical in nature, psychological in nature, can absolutely have regression of their bowel. And so for this is one of the areas that requires a really, really wraparound approach with all your multidisciplinary team. But we definitely see kids who've undergone trauma who need this sort of care and attention to make them basically feel safe. And whether that's making them feel safe from a physical perspective or a mental perspective, that's something that I'm very passionate about addressing. And it's a very tough area, but it's one of those big high impact ones.
Of course.
And then the other one is, yeah, of course, the toilet training, making that tick box, making sure that we're ready for toilet training. There's nothing else holding us back. But those are usually the main ones that come to me. And I always love the questions from parents like, I've never heard you mention this before. Do you think you could help with this? And I'm usually straight up honest, like, I have never heard of that before. These are the things I try. Why don't you try a couple of these at home? And then if those don't help, or this professional doesn't help you, come on in. Let's do an assessment. Let's see what we can do.
But again, like if someone's listening and any of this sounds familiar, you know, I'm putting words in your mouth here, but so you tell me if any of this is untrue. But when they come in to see you, not only are, you're listening to the story, you're listening to the symptoms, and you're going to look at all of these things that we've just talked about, and differently depending on the story. Like, someone comes in with through the trauma lens, you might be approaching that way more emotionally or psychologically initially. Someone's coming in with the constipation, you're going to approach it slightly different. But for every person, you're looking at the things we talked about, like the way they move, the way their habits, they're just going to describe their pee and poo. You're going to look at the way they breathe. You're going to look at the way they use their abdominal muscles. Like you're looking at the big picture for everybody, because there's never just one answer.
Absolutely. You can't use a cookie cutter approach because this is such an individualistic issue. And the other thing I think that we as pediatric therapists do, and I know I do in my pelvic floor, is I act as the family's advocate, because so often some of these families have said, I have this concern, and it's fallen on either empty ears or they don't know where to go. So sometimes I'm just a navigator. Sometimes I'm like, here's who I think you should see next. Or while we're doing this, I would love it if you talk to this person and start this sort of treatment. Or the advocate, just the other voice banging on the door is here. Like, I know the family said to you this past, this is what I'm finding, and this is why I think we should address it. So I'm very much on the family side. And so often I just love that moment when a family feels heard. Like if they can kind of feel comfortable and safe in my environment and feel heard, then I know I've done a good job.
So then what would you say are some actionable steps people can take out of this? So I think one of the things you've said, and I'm going to ask you to tell me some resources that you find you're always sharing with people, and I'll link them in the show notes. But would you go as far as to say people should start with a diary for their children, or just start noticing, maybe before you do anything formal, just start noticing, just start talking about things, having conversation, anything else that you really want people kind of take home message that they can implement right away?
Absolutely. So I think I think a diary is probably unnecessary for most people. It's a lot of work. And I know from my own experience, I have one child. I can't imagine doing a diary for more than one child or managing anything else. So I don't like to add things onto parents' plates if they don't need to. But I think the easiest one, like you said, is talking about it. what's going on? Let's talk about our poos. Let's talk about our pees. Get a Bristol stool chart for home. Be like, which one did it look like? What color was your pee? What does that mean? What should we do? That just have that conversation, because conversations are an easy way to just, it doesn't take long. We can just have this little bit of conversation. The other thing I love for families is once you're kind of starting to have those conversations, then you can start thinking about, okay, things like, what are you eating on a day-to-day basis? And God forbid I tell any parent that you need to get your child to start eating X, Y, and Z, because they'll tell me like, okay, you
Yeah.
can come over here and get my child to eat X, Y, and Z.
Yeah.
But introducing some options, some fruits and veggies, eating the rainbow, trying to make it fun and sort of things like that is a great dietary start. For fluids, making sure that, you know, that kids are drinking enough fluids, and that can vary from child to child. But 9 times out of 10, the kids I see are not drinking enough water, fluid, or like fluid-based foods. And then in terms of the toilet, I love to set things up for success in the idea of breathing and position, because those are two really, really easy things to take home. So for position, we always want kids to have a little bit of a knees above hips position. So a squatty potty, or even like your $2 stool from like Home Depot, are really, really impactful ways to change the way kids go to the bathroom. It allows really great pelvic floor relaxation, puts them into a good position, and makes sure that when the poo and the pee needs to come out, it's all able to come out. And then the other thing is breathing. Like I remember when we were first, before I even became a pelvic floor practitioner, one of friends who's a practitioner said, like, do you hold your breath when you poo? And I was like, well, that's a bit of good morning to you too. And I had to think about it. I was like, oh my goodness, I'm holding my breath. I'm straining every time I try to have a bowel movement. So there's a couple of resources I like saying for families in this case is that when they're on the toilet, for younger kids, one I love is moo while you poo. So to
Oh,
have that idea of the open glottis, the moo when you're trying to have a bowel movement, because you can't hold your breath, and it helps give a little bit of pelvic floor engagement and relaxation. Other one I really like is the idea of breathing. And I think actually I've been seeing this a lot more with elementary school kids, is the idea of box breathing is actually being taught in the classroom. And I think it's
mhm.
really, really cool. More for an anxiety and calming technique. But I love one called, or I use box breathing with some of my kiddos, but I love one called The Flower and the Candle, because it's really, really intuitive for kids. And you can look it up on YouTube. It's a great free video. And the idea is you smell a flower and you blow out the candle.
Mhm.
And
Mhm.
it naturally encourages this really nice cyclical deep breathing, and you can encourage a little bit through the belly. But if you can get your kids drinking a little bit of water, sitting on the toilet and sitting down for the pee and the poo with a little bit of a stool and trying to breathe, you're going to make a huge, huge difference. And my biggest kind of concern for families is I want to make sure that they don't come see me. I don't want to see
Mhm.
families. I want to make sure these problems never crop up, because you know what? They've been talking to their children, they've been getting the support they need, they're being taken seriously, and they've got the tools needed to get from diapers all the way to adult continence.
I I think that because again, I see how awesome would it be? I would see way less people as adults if they had some of those habits for positioning and like the flower and the candle like on the toilet, like how much that would just it just sets up habits. And I couldn't help but think that one of the things sometimes I give my friends suggestions when they're having these issues with their kids pee and poo is I say, I think, when you're saying like try certain foods or ask them to drink more water, is that always give them the power. And again, like if I think of my kids, sometimes it's like, do you see how your poo is like that? What do you think you need? Because I want them to figure out their strategies moving forward, or like, did, did you leave your fruits and vegetables in your lunch today? Like just giving them the power so that they can start to make those decisions themselves. And then sometimes I tell people to talk out loud, like when you as an adult are going pee, like, okay, I'm gonna go pee now, and then go, and then sometimes comment on like my pee's yellow, I have to drink more water. Like just lead by example sometimes, I think too, so that we're not putting the pressure on them. Again, it's trial and error. No kid is the same, right? No two kids the same.
Absolutely. And I think that's such an amazing point on, we can tell someone how to change. But if someone chooses the way they want to change, whether that's a kid or an adult, that's so much more meaningful to them. It has so much more impact, and it's so much more likely to have adherence. And that's the biggest thing we're chasing as therapists, is like, okay, I want you to change these things, but I want you to continue to do them. So
Absolutely.
if a kid takes a water bottle and they're like, I want to drink my water bottle, I want to get down to the bottom sticker.
Right.
because I also know, well, one, I've just ticked my box. I've achieved that. Like, look at me. I'm a big boy.
Mhm.
Um, but if they're also like, I know that if I drink this water, that it's not going to hurt to poo tomorrow.
Right. Exactly.
And if
Yeah.
they're like, oh yeah, I'm doing this for me, not because mom and dad told me so.
Yeah. Or yelling at me. Yeah.
Yeah. So that's huge. But it's also it's so challenging.
Oh yeah. Just ideas. What other resources do you find yourself always suggesting?
I love, I mean, I'm blessed to work with Kids Physio Group in that we have a PED specific. So we have a communication channel for our entire company, and we have a PED specific pelvic floor channel where basically we all chime in on a daily basis, multiple times per day, talking about upcoming education events, talking about current research, talking about tough cases. So that is fantastic for me, but not really much help for anyone who's not in kids physio. So in terms of go-tos for me, I find there's fantastic practitioners on Instagram who are putting out really great information. And I would say don't pay much attention to people who say they can cure something. The
Mhm.
ones who say, here's some things to try and give you reasons for it. Like, again, that self-advocacy piece. Here's why you should maybe try some things or think about these things. There's lots of really great researchers and also practitioners. So that goes for both OTs and PTs in the pediatric world. Other places I like going, I did my training through Dawn Settle-Cheaty's course, and she's got a fantastic blog online. I love Dr. Stephen Hodges' blog. He's got great pieces of information as
I
well.
recommend his book all the time. It's no accident. I find it's an easy read for parents. I always say every parent should read this book.
Absolutely. Once I have time for reading, I'm going to dive
Okay.
right into it. I know most
It's
of
a
his
short
stuff.
read. Yeah.
Oh, fantastic. So that's something I can do. That's nice and palatable. So those are main things. We always try to put out some education on our platforms as well, either through Facebook or especially through our Instagram to help out parents and things like that. But I'd say those my go-tos. Definitely the online world. I reach out to those, and I'm definitely trying to reach out to other practitioners in the community as well. So if anyone else is a pelvic floor practitioner, probably your best friend is another pelvic floor practitioner in your community.
Exactly. Awesome. Okay, well, I'll link some of those things in the show notes. Anything else? Thank you so much for your time. Any other last messages you want to share?
No, I think like just a big kudos for anyone tuning in. I mean, taking the time to learn about how you can support your kids is such an incredible way to use your time. And you've done a great job in using that time for your kids today. So thank you for listening because you're doing yourself and your kids a favor. I really appreciate it. And I appreciate you listening to us.